Hi all. Today we'll discuss intermittent chest pain, focusing on angina pectoris, one of the most important clinical presentations of myocardial ischemia. Anginal pain typically results from transient episodes of reduced blood flow to the heart muscle, leading to temporary oxygen deprivation. Patients usually describe it as a dull, tight or pressing band-like discomfort, often likened to a heavy weight or pressure on the chest. The pain is usually diffused, felt across the anterior chest and may radiate to the arms, throat, jaw, or teeth. In stable angina, which results from chronic narrowing of one or more coronary arteries, episodes of chest pain are precipitated by exertion or emotional stress. Common triggers include walking briskly, climbing stairs, cold or windy weather, and large meals. The discomfort usually subsides within 10 minutes after rest or administration of sublingual glyceryl trinitrate, or GTN. The severity of coronary disease correlates better with the amount of exertion required to provoke pain rather than the intensity of the pain itself. Clinically, chest pain can be categorized as typical angina, atypical angina, or non-anginal pain. Typical angina meets three criteria. Discomfort is substernal, precipitated by exertion or emotional stress, and relieved by rest or GTN. Atypical angina meets two of these, while non-anginal pain meets one or none. The presence of typical angina significantly increases the likelihood of obstructive coronary artery disease. In unstable angina, there is a sudden worsening of symptoms or pain that occurs with minimal exertion or even at rest, due to abrupt plug rupture or thrombotic narrowing. This form of pain may signal impending myocardial infarction and requires urgent evaluation. It's also important to differentiate angina from non-cardiac causes of chest pain. Esophageal pain can mimic angina, but is often related to swallowing, lying down, or reflux. Musculoskeletal pain tends to vary with posture, movement, or palpation, and can occur anywhere over the chest wall. When taking the history, always ask about the site, onset, character, severity, and radiation of pain, associated symptoms such as breathlessness, aggravating and relieving factors, frequency and duration of attacks, and any recent change in pattern. Also assess the degree of limitation the patient experiences during daily activities. In summary, understanding the characteristics and triggers of intermittent chest pain allows clinicians to distinguish between cardiac and non-cardiac causes of chest pain, identify patients at risk of coronary artery disease, and initiate timely management to prevent serious cardiac events. Thank you.